Mom deserves the best, and there's no better place to shop for Mother's Day than Whole Foods Market. They're your destination for unbeatable savings, from premium gifts to show-stopping flowers and irresistible desserts. Start by saving 33% with Prime on all body care and candles. Then get a 15-stem bunch of tulips for just $9.99 each with Prime. Round out Mom's menu with festive rosé, irresistible berry chantilly cake, and more special treats. Come celebrate Mother's Day at Whole Foods Market.
Welcome to PharmacyToDose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. Now let's hear from our sponsor, QXMD, before we get started today. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out Read for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. Well, I certainly hope that everyone is staying safe, staying sane out there. I know most of our worlds have kind of gotten turned upside down in the past month. So just hope everyone is taking heed and is remembering to take care of themselves. But today I'm very grateful to be joined by Todd Miano to discuss statistics and research during the COVID-19 pandemic. I think any one of us who has done a recent literature search has seen that we've had a massive increase in COVID-19 related publications, and they haven't been perfect or high quality research in many or really close to all instances. So I really thought that having someone as knowledgeable and talented with these statistics and research as Todd, he might be able to help us out with research and interpreting and applying this research, really during this unprecedented time in medicine and especially in most of our lives. Now, Dr. Todd Miano is an instructor of epidemiology and a critical care pharmacist at the University of Pennsylvania Perelman School of Medicine. He is an elected fellow of the American College of Critical Care Medicine and is an associate editor of BMC Pharmacology and Toxicology. His research leverages electronic health record data to study drug safety and comparative effectiveness in the hospitalized and critically ill populations. In particular, his work focuses on drug-induced acute kidney injury and understanding factors that underlie variability in drug response, including pharmacogenetics, drug-drug interactions, and drug-disease interactions. So thank you so much for joining me today, Todd. How are you?
Hey, Nick. I'm doing well. Thanks for having me on. I'm really excited to have this opportunity to talk about research principles and how they apply in this kind of unprecedented time where we are in the midst of a pandemic and we have this kind of unprecedented ability for researchers across the world to address this research question. So that we find ourselves kind of overwhelmed with information. And so, I think being able to kind of parse through what's good information, what's bad is especially important now. And so I'm really thankful to have the opportunity to discuss this today.
Yeah, overwhelming is somehow maybe an understatement if you're trying to read everything that's getting published. Now, we have to discuss an important question since you're a Philly guy. So where's your go-to cheesesteak establishment?
For me, it's pretty clear. Pat's. There are a lot of places in the city. The two most famous, I think, are probably Pat's and Gino's in South Philly. And what's kind of remarkable is that they're right across the street from each other. And so when I first moved to Philadelphia, me and my friends, that was like the first thing that we did is we went down the South Street. We went to Gino's, got in line, stood in line for an hour, got a cheesesteak, and then we went right across the street to Pat's and tried that one out. So if you're in the city and you want to after you get done running the art museum steps like Rocky, head down to Pasagenos, and you'll have a good trip.
Now I'll just say, I have one of my good friends, shout out Jack. He's from he went to Villanova, and he introduced me to a hole in the wall cheesesteak place. It's called Falone's. Falone. It's one of those. It's like a gas station. It's like a package store and things. But I have not had a better cheesesteak to this day. So it's one of those. I'm recently vegetarian with my wife, and these are some of the few things that I think no matter how long I'm gonna miss, certainly.
Yeah, I haven't been to Falone, so that might be whenever they open the city back up, that might be one of the first places I check out.
Now, what initially made you interested in statistics and research? Because, judging from just my knowledge of you in the bio, a large part of your professional career is focused on just that.
Yeah. So, I think I've always been curious by nature, and I think that's the kind of personality type that lends itself to doing research. I love I love just trying to figure out the puzzle. Research as a career never really crossed my mind until my first rotation as a fourth-year pharmacy student. It was at the University of Virginia in the neurocritical care ICU. And this was shortly after the initial vancomycin guidelines were published that for the first time recommended troughs between 15 and 20 for hospital-acquired pneumonia and other infections. And so, I'm a student. I really have no idea what I'm doing. We talk with the preceptor. We need to increase the vancomycin dose to target the trough level. So I go to the team and I make the recommendation, and the attending physician immediately goes, I say we need to increase the dose from a gram Q12 to 1.25 Q12. And the attending says, why? And, as a student, getting that kind of question right off the bat, and, I'm starting to get flustered. And so I'd say, well, because the level is 10.6 and we need it to get to 15 to 20. And he said, why? And I said, well, because that's what the guidelines say. And he said, are those guidelines based on any information? What's the studies that have validated that? And then he proceeded to kind of talk about the development of the guidelines and the fact that at that time it were based on expert opinion and that we really didn't know, and kind of suggested, why don't you look into that? And that's something that you might be able to even do yourself. And for me, that was kind of an aha moment. Especially as a student coming out of pharmacy school where you're used to taking tests and there's always a right answer. So kind of realizing that in the real world, there often isn't a right answer and no one knows. And the notion that I could contribute to that was really, really exciting. The notion that there's questions out there that no one knows the answer to, that we're all having to deal with, and that I might be able to contribute to answering that question in some way was just really, really exciting as a young pharmacy student. And so when I eventually got to residency, I knew that I was really looking forward to the research aspect of the experience and kind of threw myself into it. And so, from that moment on, I've always wanted research to be a big component of what my job was. Right out of residency, I was a full-time clinical specialist in our surgical intensive care unit. But after a few years, I found myself more and more focusing on research, and eventually did a research fellowship, and now I'm kind of doing research full time.
I think you just played out every student's worst fear when you're making a recommendation is the constant why. But I think everyone's very proud of Todd, the student, because you didn't say my preceptor said to, right? You at least said the guidelines said. So that was a solid first step. Now, before we specifically talk about some of this COVID-19 literature and your thoughts, you give us an idea, and I think this could be helpful, not only for what we're going through now, but just in general from your unique ability and knowledge of research and statistics. When you look at a research article that was just published, kind of walk us through your thought process and how you work through reading and analyzing the publication.
I think that's a great question because I think so much about literature evaluation. There are nuances for particular study designs in particular areas. So I think talking about some points that apply more broadly is very helpful. And so there are a handful of things that I think are always helpful to think about and to be aware of. So the first is kind of what is the question being addressed? Think about the sample size. There are some broad implications of the sample size of the study. How well were the methods described? And then, a couple of points about general issues with analysis of study results. So focusing on the first point, what is the question? I think this is often the key aspect of study design. When I was in research training, one of my mentors, his constant refrain was the question is, what is the question? A lot of issues that arise in study design that translate ultimately into bias and published findings is a lack of a clear study question that's being targeted. If you have a clear question, knowing what the right answer in terms of choices for study design becomes a lot easier. So the question is, what is the question? So, for example, let's say that we're interested in hydroxychloroquine. So our kind of broad question is, does hydroxychloroquine improve outcomes in patients with COVID-19? So that might, at first glance, seem like a reasonable question, but if you think about it more critically, there's a lot of detail that is left out. So what exactly is the question? Improved outcomes. Well, what outcome? And at what time? Is your question focusing on a surrogate marker like viral load, or are you interested in clinical outcomes like the need for intubation or mortality? Those are the answer to that question will lead you to drastically different study design choices. What does treatment mean? So this is kind of in pharmacist's wheelhouse. What dose, what duration, started at what time, and compared to what? What is the comparison that is being made? And then finally, what is the specific patient population of interest? Are we interested in prophylaxis in patients who don't have disease, treatment of mild diseases, or are we focused on critically ill patients? So a very specific and well-developed question addresses each of those factors. And I think so that's the general thing to think about in terms of the question is, what is the question? I think one point to emphasize specifically for COVID-19 is the importance of having a control group, specifically when you're thinking about questions that are trying to determine the effectiveness of treatment. And so, Nick, I'm sure you've seen recent studies where we treated 30 patients with a drug. We don't have a control group, and these were their outcomes. And then there are conclusions made based on that study without a control group. So, what is one to make of such a study? Have you come across any of those, Nick?
It feels like that's all I'm reading with the COVID-19 is research with a lack of control group, just a descriptive analysis of treating patients with some sort of intervention.
Yeah. So the question then is, can you determine effectiveness or lack thereof from that type of study? And so the short answer is no, you cannot. It is generally impossible to draw any meaningful conclusions from a study that is aiming to measure drug effects that does not have a control group. So there are scenarios where that type of study might be able to work. It's scenarios where the mortality would be exceedingly high. So the classic example is parachutes and jumping out of an airplane. So, if you jump out of an airplane, your mortality is going to be near 100%. So if you have a study of 10 patients who jump with a parachute, they all survive, that's pretty good evidence that wearing the parachute is a good idea, because the outcome without a parachute is nearly certain. We know by common sense, if you jump out of an airplane without a parachute, we know what's going to happen. So single-arm studies that don't make a comparison can show effectiveness if the effect is really, really large. The challenge is that most treatments that we use, the effects are not very large. Most effective treatments reduce the risk of an outcome by 20 or 30% on the relative scale. And so when the effects are small, it becomes much more difficult to look at the outcomes in the study and say, well, that's higher or lower than what I would have expected. What also makes it difficult is when the disease of interest has a wide range of severity, which is certainly true for COVID-19. Some patients are completely asymptomatic. Other patients are critically ill, requiring mechanical ventilation in the ICU. And so when you're faced with a study that doesn't have a control group, the question then is where do the patients in that study fall on the spectrum of disease illness? And so we would need to know that with near certainty to be able to judge the results in the arm that's presented. Are the results good or bad? Well, it depends on what would have happened if they were not treated. So in general, of all the studies that we're confronted with, the drug therapy studies that don't have a control group are the most challenging. So the next factor that I think is important is how the methods are described. So after reading through the study, do you feel like you have a good idea of what they did? Do you think you can replicate what they did? And so a general rule of thumb that I think is helpful is if they don't describe it in their methods, assume that they didn't do it. Science kind of works on the honor system. If a study is a randomized controlled trial, for example, the only way that you or I know that it was actually randomized is that they tell us that they did it in the methods. And the only way that we know that they did it effectively is they describe exactly how they did it. And so reflecting the importance of this kind of high level of detail in describing the methods and the transparency of what was done, it's commonplace now for studies to be accompanied by supplementary appendices where the details are described or the methods are described in great detail. And so I think the rule of thumb is if they don't describe it, assume they didn't do it. And the reason I say that is that, in my own experience, if I have an important aspect of study design, how to define the outcome of my study. And I've spent a lot of time thinking about it, and I've developed this very detailed, in-depth algorithm to define my outcome. You can guarantee that I'm going to include that in the write-up of the paper. And so it's reasonable to conclude, I think, often that if the methods, if the way in which outcome was described, for example, is just a couple of lines and doesn't have a lot of detail, it's safe to assume that perhaps the investigators didn't put a lot of thought into how they actually implemented that aspect of the study. So in general, be it an observational study or a randomized controlled trial, if it's poorly described, it's a sign that it may have been poorly conducted. And the last kind of broad thing that I would mention is in terms of data analysis. And the key here is the goal is to have analyses that were pre-specified, meaning that before the investigators looked at the data, they had planned out how they were going to analyze the data. And so factors that go into that include deciding in advance what is the primary outcome of interest and at what time point are we going to measure it and make a comparison. And then, how are we going to analyze it? What type of statistical model or statistical test is going to be used to make that determination? And so pre-specified analysis is essential. And so you're wanting to look for evidence of that. Sometimes that can be challenging to determine. For that reason, that's why there's been a push in recent years for studies to be pre-registered, predominantly randomized controlled trials, but it's becoming more and more common for studies of all types to be pre-registered. And so, and the idea there is that you say, this is my primary outcome, this is how I'm going to analyze it, and you can point back to that once you actually have the results, say, this is what we said we were going to do, and we in fact are doing just that. The concern about analyses not being pre-registered is kind of has to do with cherry picking data. So if you haven't really thought out, so let's say for example you're interested in the effect of a treatment on viral load of COVID-19, and so what you know is you're going to start treating patients and compare treated to untreated patients, and you're going to follow them forward in time. But you haven't really thought through, well, at what point should I measure differences in viral load? And so you measure all the data, and then you start looking at the data, and you're not sure, should I look at day 4, 5, or 6, or should I look at 2 weeks? But when you look at the data, you notice, well, the biggest difference was on day 6. And so, well, let's just report day 6 because that's the biggest difference, and that's the most interesting. And so, that's the type of scenario where you are following patterns in the data that may just be random noise in the data. So that's an example of post hoc analysis, and that's why when you hear the term post hoc, we don't give it as much credibility as a priori specified analyses. So if you haven't planned out in detail how you're going to analyze data, you're setting yourself up for for following kind of random patterns in the data that can lead to spurious findings. So those are, I think, some broad ranging things to think about that hopefully can apply to most study types.
Oh, that was great. And you brought in, the parachuting research and statistics. That's one of my favorite analogies to bring up. And I guess I just have to say it. I think we all know this, but you jump out of a plane, there's just about 100% risk that you're going to pass away from that. Now, we cannot definitively say in any of these COVID-19 trials that we can say with certainty that this patient would have lived or died, right? 0% die or 100% die. We're not at that point, correct?
Absolutely not. What we know is that on average, if we were able to measure everyone in the world who has been infected, meaning that everyone was tested, that the mortality rate across everyone would probably be in the neighborhood of 1%. Most folks think we're underestimating that because most patients haven't been tested. So 99% of the time, on average, you're going to survive. With that, if you're looking at a study without a control group and you don't have a good idea of the severity of illness of the patients included, well, the default answer that you would expect is that all patients survive. So, that spectrum of disease severity is what makes it so challenging to interpret these studies without control groups.
Why do you think we're seeing so many of these single center, single arm research studies being published? Do you think it's because when I think of it, my thought is it's A, everyone's just trying to publish as much as they can, and B, everyone is realizing they're just trying to help, I think, at the end of the day, and they're doing everything they can. But if we have 30 very low quality or even uninterpretable studies versus 1 to 2 high quality, it really makes treatment decisions and implementing these new experimental therapies more challenging.
Yeah, absolutely. I think, first of all, I think we're in an unprecedented time in that we have this, we're in the midst of a pandemic that's affecting the entire world, that has everyone scared, for which we don't have any way to prevent or any way to treat. And so everyone is very motivated to find answers to improve outcomes for these patients. And so I fully agree that the deluge of data that we see, much of it may be poor, but it's all coming from a good place. I think everyone's coming at this with good intentions. I think it's driven in part by just the sense of urgency that we have for trying to find answers. And I think the journals have kind of gotten caught up in that as well. Journal editors are human just like you and I, and so they sense the urgency. You're seeing publications published in high impact journals that 6 months ago you absolutely would not have seen. And so the default, I think, for many people is that some data is better than no data. But I think what we're starting to realize now is that may not be the case. It may be the case that bad data is worse than no data, because if the only data you have is bad and it gives you the wrong answer, and then you go and act on that, you very well could have made things worse than not having any information at all. So I think that rule of thumb, that some information is better than no information, we might have to refine that a bit. The other factor is that science is really, really hard. Science is very challenging. It takes a really long time. And science doesn't really care about the urgency of, the time frame in which we need the answer. Given the technology that we have available to us, it just takes a certain amount of time to do things and to do them correctly. And so, I think we are kind of running up against that headlong in the current situation, where we're just, trying to do things much more quickly, making shortcuts here and there. And so, we're in the midst of it. And so we won't know the full implications of this, but I do think that there are going to be some long-ranging implications for science in general of how we've responded to this crisis, and kind of where we went wrong, and then hopefully we'll be able to determine what we've done right as well.
Now we're still learning about the COVID-19 coronavirus and everything that we can potentially do to help treat it. And, I'm seeing a lot of articles being published that may discuss in vivo or in vitro efficacy in relations to kind of some of these experimental treatments or medications. So why doesn't in vitro efficacy always translate to in vivo efficacy or safety or what have you?
Really fantastic question. I think there are more people being treated based on in vitro data now, perhaps, than at any other time. So, it helps to just define the two terms. In vitro means in the test tube. So an in vitro study is based on data that came from some artificial environment. So it's outside of the organism. So the classic example is we take some coronavirus, we put it in a test tube, and then we inoculate the test tube with various antimicrobials and see, does the antimicrobial inhibit growth or kill the virus, and at what concentration does it achieve that? So that's the type of information we generally get from in vitro studies. And so then the question is, will that work in vivo? So broadly, in vivo means in the organism. And that includes, in vivo studies include both animal studies and human studies. And so, we could talk a lot about, the translation of in vivo studies between animals and humans as well. So the question then is, in vitro data, this antimicrobial inhibits growth in a test tube. Will that work in humans? That's kind of really what we are all wanting to know. And so again, this is the factors that determine that question are kind of in pharmacists' wheelhouse. So whether or not a drug that has activity in the test tube will work in humans has to do with how that drug is delivered. So what dose, what duration, who is it given to, and will the regimen selected of a given therapy achieve effective concentrations at the site of action? So it's a lot of what determines whether it will translate has to do with pharmacokinetics and pharmacodynamics. And so for many treatments where all we have is in vitro data, we know very little about how a regimen should be designed to be effective in humans to treat the actual disease, and whether or not it would be safe. So, that's one thing that in vitro data often give you no hint of information about is the potential safety and how that might offset against potential benefit. There's a good example of where in vitro activity likely does not translate. So ivermectin, you may have seen some recent discussion of this on the ACCP ID listserv. Ivermectin has fairly potent activity in the test tube, but if you look at the peak concentrations attained at steady state in the relevant tissue beds, they're several fold lower than the concentrations that would be required to actually treat the virus. So a good example of how in vitro data often are not going to translate into outcomes of humans, unfortunately.
Now this idea to kind of discuss research and some statistics, it all came from what I guess I'll call the study read around the world, which was the initial hydroxychloroquine azithromycin article. So break down, and I'm sure there's probably thousands of different areas, but what are the risk of confounders in a study like that? Non-blinded, non-randomized kind of, research study.
Yeah, absolutely. I think a more apt description might be that it was the study tweeted around the world. I don't know how many people actually have read it. Certainly in the lay public, and in our leadership, whether or not they've critically read the study and evaluated it is unclear. But it certainly has been kind of the emblematic of all the issues that we are concerned about in trying to sift through all this information. That study was a small study, included 42 patients, non-randomized, where they compared patients treated with hydroxychloroquine, 26 patients treated with hydroxychloroquine versus 16 patients that were not treated with hydroxychloroquine. And so, and everyone, has probably seen the figure that has been tweeted around and publicized, where they looked at viral load over time, showing that viral load was more quickly eradicated, or apparently more quickly eradicated than the patients treated with hydroxychloroquine. And specifically, there were 6 patients that somewhat kind of arbitrarily had received azithromycin. In those patients, it was the results were most promising. The effects, the benefits seemed the largest. So what are we to make of this study? So first of all, there were only 42 patients, and so kind of harkening back to what we talked about with sample size. Small studies are known to, the thing that I think folks think of with small studies is that they're underpowered, and so they're more likely to miss an effect if in fact there is an effect to measure. But I think a more accurate way to think about sample size is that small studies just have more random error. And so that affects both false positives and false negatives. So any measurement that we make in a study, the observed effect, is the sum of the true effect plus random error. And so there's more random error in small studies compared to larger studies. As sample size increases, the random error gets smaller and smaller and smaller. So a small study is both more likely to underestimate the true effect and more likely to overestimate the true magnitude of benefit. And that is the key thing to remember. So small studies are only powered to detect very large differences in outcome. Small studies are only powered to detect really large effect sizes. And it turns out that for most treatments, effect sizes are small to moderate. And so the implication is that, in general, for positive studies, small studies that are positive, on average, they're going to overestimate the magnitude of benefit. And so that is just a general rule across all study designs, randomized controlled trials, observational studies. So the first point to make about this study is that even if the results reflect the true effect, it's more likely than not that the magnitude of benefit observed in that study is an overestimation of the benefit. And so that's assuming that everything else about the study was done perfectly. So that kind of addresses the random component of error in a study. The other sources of error are kind of what terms of bias. Those are systematic sources of error. And we break those down into kind of 3 broad areas. The first is confounding. Second is selection bias. And the third is information bias or measurement error. And so you mentioned the first factor, confounders. So, and I think these terms often get confused and kind of used in different ways, but they each have a very specific definition. Confounding has to do with differences in the risk for the study outcome at baseline. So this has to do with, comparing apples and apples, or are you comparing apples and oranges? So the reason that we have table 1 in studies where we show the characteristics of patients at baseline across treatment groups is to kind of get at what is the risk of confounding in the study. And so, and in fact, confounding is the only reason that we use randomization. In fact, that's the only benefit that randomization provides, is that it deals with confounding. So are the patients being compared similar, or is one group sicker or less sick than the other group? And so differences in outcome risk at baseline then get mixed with any effect that might be due to the drug. so that at the end of the day, when you see differences between the groups, the question then is it due to the effect of the drug, or is it due to the baseline differences that were in the patient groups at baseline? So in observational studies where treatments are not given at random, you can kind of just assume by default that there's some degree of confounding there. And the reason is that we don't give treatments at random. We give them following good clinical practice. We tend to give treatments to patients who are most likely to benefit and avoid giving treatment to patients who are at the highest risk of experiencing adverse effects. So as a general rule, you can expect that a study comparing treated versus untreated, the treated patients will be systematically different in some way compared to the control group. And so how much should we be concerned about confounding in the study tweeted around the world? Well, it's hard to say because they don't do a good job of describing the two groups that were being compared. And so this kind of gets back to, if they don't describe what they did, it can be a red flag on how valid the data are. We don't have a good description of the patient populations. What we do know is that the hydroxychloroquine treated patients were on average 20 years older, thereabouts, than the untreated patients. So using just that number alone, I think it's safe to say there were probably some systematic differences across all relevant baseline characteristics. So confounding, I think, certainly is an issue. And as I mentioned, kind of in general, in observational studies, confounding isn't always an issue. The other really important thing that we mentioned is selection bias. And I think that this may even be a more of a concern in this example than confounding. So selection bias has to do with how patients were included into the analysis population. And selection bias occurs when the likelihood of being included in the study is related to both treatment and outcome, meaning that treated patients were systematically more or less likely to be included into the study based on their outcome risk. And so when that happens, the effect estimates from the study can be distorted. And kind of a red flag is when there are any inclusion criteria applied after time zero in the study. So if you read statements like, to be included in the study, patients need to have a minimum of 5 days of follow-up, for example. Those types of exclusion criteria are perfect setups for inducing selection bias. And so in the study that we're talking about, they only included patients that had a minimum of 6 days of follow-up. They don't describe why a minimum of 6 days, but that's what they did. And so of the 26 hydroxychloroquine treated patients, they dropped 6 of the patients out of the analysis because they didn't have 6 days of follow-up. And the reason that all 6 dropped out had to do with the outcome of interest. 5 of the patients dropped out because they were transferred to a higher level of care, which is kind of the essence of the outcome that we're interested in. So 5 of the patients got worse in the control group, and those patients were excluded from the control group. The 6th patient stopped treatment because of side effects. So again, kind of related to an outcome of interest. So here you have the systematic exclusion of patients from one arm, from the treatment arm, based on their outcome. So that is kind of the definition of selection bias. And that alone is enough to really put the results, to really make the results uninterpretable. So, and this is true for many of biased studies. When you uncover a bias like this, you don't know if that fully invalidates the findings, but you don't know. It really makes the findings uninterpretable. So it means that the study doesn't really add a lot of useful information. So, whether or not hydroxychloroquine is effective, I know really not any more about that answer after reading the study than before reading the study. So it just minimizes the information that it provides. So selection bias was a key issue for that study. The last thing that I mentioned is information bias or measurement error. And so this has to do with how accurately and clearly the exposures of interest in the study and the outcomes have been defined. And so if you do a poor job of measuring exposure, a poor job of measuring outcome, that, again, can induce important bias. And so, a thing to look for in these studies is, have they done a good job of defining exposure? Are they thorough in describing the doses that are used, the duration of treatment, the frequency, all the relevant aspects that would be relevant to treatment response? And then do they have good, thorough outcome definitions? So, so getting back to your original question, I think confounders and a number of other biases are certainly of concern when trying to interpret the results from that study.
Now, you had mentioned earlier, the journal editors are under, they're human as well. They're under just as much kind of pressure to, publish and release information, probably just as many of us kind of feel. So how much should we be concerned about, publication bias during this, massive amounts of COVID-19 research that we're experiencing and reading right now?
Really fantastic point. So, I think at baseline, always publication bias is an important concern. And meaning that studies that have positive results tend to be published more often than studies that have negative results. Meaning, a study that has a significant difference in the direction of the hypothesis, those studies are more likely to be published than negative studies. And the reasons kind of reflect, first, I think, human nature. We're drawn to positive findings. We find them more interesting. We're more likely to read a study if it says this is a beneficial drug than it's not a beneficial drug. So it somewhat, I think, reflects human nature. And it also reflects the fact that journals are competing with each other. So they're all competing for readers. And so they want to publish research that is the most interesting, the most novel, the most exciting. And so positive studies tend to fit those criteria more often than negative studies. And so at baseline, and this has been true for decades and has been well described, there's a bias in the literature towards positive findings. So that's the first thing to be aware of. The second thing is that, so is that risk any different now than it always has been? And I think there's a reason why you might suspect that publication bias is more of a concern now. And the reason has to do with how we test hypotheses. So we use frequentist statistics to test hypotheses. So that meaning, we use p-values and statistical tests to calculate p-values and then compare the p-values to a threshold to determine yes or no, the result was different. And the threshold that we use by convention is 0.05, meaning that we are willing to accept a 5% rate of false positives. And so that's what the p-value threshold of 0.05, that's what it implies, that when we make comparisons across multiple comparisons, we can assume that there will be a 5% false positive rate. So that if we conduct 100 studies of a treatment that we know is not effective, let's say we randomize in 100 different studies to placebo versus another placebo. Now, I don't know why we would do that, but for the sake of this example, let's assume that we did that. Mm-hmm. Across the 100 studies, on average, you would expect 5 of them to have a significant difference in the outcome, due just to chance alone. So there's going to be a set number of false positives across multiple studies. Now, remember that there's a bias in the literature towards publishing positive studies. So those false positives are more likely to be published than false negatives across all those trials. And so, in 100 studies, there would be 5 false positives. Think about how many studies of COVID-19 are being conducted right now. Not just 100 studies. There's likely thousands upon thousands of studies. Everyone in the world, basically, right now is kind of shut down research for the most part, and is focusing on COVID-19. And so given the bias towards positive studies that is embedded in the literature framework and the way that we test our hypotheses, you can guarantee that there are a lot of false positives that are being published. So I think publication bias is important and should always be in the back of your mind, but especially an important consideration now. How do we, can you avoid, can we, how do we deal with publication bias? I think that's a challenging question that the research infrastructure has been dealing with for a long time. The solution is the solution would be if all studies that were ever conducted were published in some way and available in the public record, then, when you do a meta-analysis, for example, you could see all the negative studies and all the positive studies. But unfortunately, we're still a good ways off from having that type of infrastructure. So for a clinician reading a given study, you just have to kind of have this in the back of your mind and perhaps have a bit higher level of suspicion when you're reading results that seem maybe too good to be true. And, I think there's an old saying, right? If it's too good to be true, it probably is. And so I think that's a useful rule of thumb in this area as well.
I mean, I'm reading studies that, they have patient outcome centered endpoints. And then when you dive into the actual study or the statistics, you find that some of these patients that they're describing in their study, they are literally still in their ICU being treated. We have no idea as to where they went. I mean, when I'm reading a study like that, and you have a percent of those patients that they're including in their study analysis, but it's like they're at the fork in the road. You don't know where they're going. Maybe more aptly, they're at the place where they have 6 different crossroads they could take. Can we take anything from those studies? Because I was shocked when I read that.
Yeah. So, what I love about this is the answer to your question is, the question is, what is the question? And so this is a great example of studies not having clear questions. So what is your question? If your question is the effect of a treatment on 28-day mortality, and you only have 28 days of follow-up on 10% of your patient population, then the study that you conducted does not address the question of interest. Now, if you don't clearly specify that question in your mind when you're doing the study, then you end up with these types of studies that kind of have indeterminate results. So when reading that type of study, a question that you might ask yourself is, what is, from my perspective, what is a relevant outcome? If they looked at mortality, what type of mortality outcome would I judge being important? And if that's not, if that's 30-day mortality, for example, and you look and the average duration of follow-up in the study as it stands today is 7 days, well, then that study doesn't really provide you much information on that outcome. So it's really kind of making that, judging for yourself what's a clinically relevant endpoint, and then does the follow-up in this study have adequate information to address that? So, if and it may be, and there may be scenarios where a 14-day outcome might be relevant, and they've got, patients are still in the ICU being cared for, but they've got 80% of the patients have 14 days of follow-up. That's a reasonable amount of information where you might be able to make an interpretation. But if only 15% of the patients have been followed for 14 days, it's really, it makes the study kind of completely inconclusive.
You're mentioning, what is the question and what is the outcome? If you were designing, one of these studies in an ideal world, what do you think, based on what we know now, what should be the ultimate endpoint or primary outcome of these trials?
So, I don't know that it's any different than how we think about, other study questions. Patient-oriented clinical outcomes that we care about. And that likely depends on the patient population. So if we're focusing on an outpatient population, the rate of hospitalization sounds like a meaningful endpoint that we would be interested in. If we're focusing on the broad hospitalized population, the rate of the need for critical care level of care, the need for intubation, mortality. I think those are meaningful outcomes. Now, those are often the most difficult to study because they take larger sample sizes and they take a longer time to achieve. So there's a push to look at surrogate outcomes. The challenge with surrogate outcomes is we only put value in a surrogate outcome if it plausibly predicts the real outcomes that we care about. If you're excited and wanting to work on research right now, and you're not able, you don't think it's going to be feasible to look at the hard outcomes that we care about, you have to think very critically about your surrogate outcome. And your goal would be to, be able to clearly describe the causal pathway between the surrogate outcome, between the treatment of interest and its effect on the surrogate outcome, and then the pathway from that surrogate outcome to the outcome of interest. So that, I think those are the things that we need more of. That in general, we put a premium on fast and first rather than being right. And so hopefully we start moving away from that in the coming months.
Yeah, that's an awesome point. And I just want to reemphasize it, like people using, say, surrogate outcomes for viral clearance or things like that. If we don't know that there's a direct relationship between the viral load and your outcome, then this surrogate outcome that you're doing to monitor is great, but it might not give us those patient-centered outcomes that we've ultimately come to look for and really value as endpoints. So I just wanted to reemphasize that really incredible point you made.
Yeah, absolutely.
Now, within critical care, and we have a few landmark critical care articles, there's 0 COVID-19 articles that fall into that, but the majority, a lot of those trials and studies are international based, right? The IRBs are a little bit easier to get some of them through. Now, because of the COVID-19 timeline, right? A lot of the studies that we're interpreting and looking into include, right, research that's being completed internationally, whether it's in, Italy, Korea, China, Iceland, what have you. Are we able to apply evidence from those international patients to, treating patients in the US? Or what are maybe things that we need to keep in mind when looking at some of these international studies?
Really great point. As is often the case, I think it probably depends. I think in general for drug therapies, the question is, or the answer is often likely yes. Things to think about though are, and the reasons that that a study result might not generalize is if there are plausible reasons why the effect observed in the international population would not be observed in U.S. populations. So what are types of factors that might alter the effect of a therapy? And so, kind of going back to biologic plausibility. So, are there for a drug that is highly metabolized? Are there genetic variations in metabolism that might affect the dose response for the medication that might differ across populations? Are there differences in the natural history of the disease that might vary across populations? Are there differences in the way that the therapy is implemented in terms of the doses that are given, the timing of the implementation of therapies? So I think those are some things to think about. But short of those types of factors, I think a lot of treatments may be able to be generalized across populations, assuming that all the other factors that we've talked about, aren't major issues. So if you have a study result that's from a large, well-designed study, that you kind of believe the internal validity of the study for that population, if there aren't factors like genetic variances in metabolism, for example, without those types of factors, I think often the results can be generalized.
Is there any risk of us using this experimental therapy? And I ask because, you mentioned in terms of research right now, we're kind of on the path of fast and first. And that's obviously what a lot of other large groups within American society have been doing. And I think anytime anyone sees an article with even an inkling of success, right? They're reading a headline, or like you said, the study tweeted around the world, right? They read that study title and instantly this is the new best drug. It's going to save everything. I mean, what's the risk of using these therapies with obviously having just built on, like you've described in really great detail, on flawed studies, just flawed from beginning to end for a lot of these?
Yeah, so I think this comes down to it's about weighing risk versus benefit, and so I think this is an area where clinicians are well equipped to kind of think about this. We want to treat in scenarios where the benefit is likely or at least plausibly likely to outweigh the risk. And so to make those decisions, right, we need information on both the benefits and the risk. And so, take hydroxychloroquine and azithromycin, for example. Should we use that therapy? Well, it depends. So we know that, two known effects of these drugs are potentially that they prolong the QT interval, which may lead to the risk for life-threatening arrhythmias. That's a seriously bad side effect. So for that reason, should we say we mandate no one's going to be treated with this therapy? Well, I think a clinician would say that's not how I would think about it. What is the risk? What do we know about the risk of those adverse effects? Well, for the combination, we actually don't have good data on what the rate of ventricular arrhythmias or other life-threatening arrhythmias would be with the combination. Just based on what we know about drug-induced arrhythmias in general, the incidence is probably fairly low in terms of, a number of events per 1,000 patients or, maybe per 5,000 patients or so. But still, that's a major risk, that's certainly patients and clinicians all care about, something like a ventricular arrhythmia. We do know that the combination, that there's been a couple recent studies showing that there seems to be at least additive effects on QT interval. So QT prolongation may be a bit worse with the combination compared to either drug alone. So we do know some about the risks. There are definitely, it seems highly likely that there are some risks to this combination. So does that mean we should never use it? Well, we don't know if the drugs work. There's some data that suggests that they might work. So, under what scenarios does it make sense to take a might work benefit weighed against the known risks of adverse effects that are likely low? Well, I think a lot of ICU clinicians have a feeling for that. If you're in the ICU, if you're critically ill in the ICU, and your risk of mortality is likely a coin flip, that's a scenario where, as you can probably tell from the past hour of conversation, I tend to be a skeptic. But that's a scenario where I might say, let's treat with hydroxychloroquine because, I understand the risk, but given the scenario, it's probably worthwhile to take those risks because any chance of benefit would be of value. But if you're talking about treating asymptomatic patients or using it as prophylaxis, that's a completely different decision. Those are populations where we might be treating, if you think about the number of patients likely to be infected with coronavirus by the end of this pandemic in the United States, you're talking about potentially hundreds of millions of individuals. And so let's assume that we're going to broadly apply this therapy to 100 million patients. And let's say that the rate of sudden cardiac death is 1 out of 5,000 patients. Well, you apply that to 100 million patients, and that's 20,000 extra sudden cardiac deaths in the population. So is that worth the potential benefit? Well, we don't know what the benefit is. So see, that's a totally different dynamic for the decision. That's a scenario where I think a lot of people would say, I don't know if that theoretical benefit outweighs the risk of, a good likelihood that there's going to be extra sudden cardiac deaths in the population. So that's kind of how I try to think about it. Doing your best to try to come up with a sense for the potential benefit of the therapy, the potential risk, and then trying to balance those.
And that explains why hospitals may, and especially, intensive care units may be using these medications more because the risk benefit is now been tilted potentially in favor of the benefit. Whereas, they also have the monitoring, right? Where they can look and see if these patients' QTs or EKGs are showing those risks of those life-threatening arrhythmias where if, say you have these, you're fairly asymptomatic, maybe you can't really, smell or taste or things like that. And then, they want to do this treatment. Well, then suddenly maybe the risks are higher. You're not monitoring and things like that. So really, really great point.
Well, and I think, this highlights the nuance of medicine, right? This highlights the nuance of being a clinician that clinicians, kind of get intuitively and I think that gets lost in the broader discussion that has been playing out in the media in our country, in the lay public about these therapies. They don't get the nuance. It's, well, this treatment works and we should use it, or it doesn't, it kills people. And it's not black and white like that. It may work and it may also kill people. But it depends on the clinical context. That's what clinicians, that's what pharmacists, physicians, nurses spend, decades of their life receiving training to understand that nuance. That's one thing that I think we could benefit from. If we had folks that could communicate that nuance, we would be a lot better off.
Now we're kind of in this, like coronavirus bubble right? Where everything is focused on COVID-19 at the moment. So how do you think that this is going to affect other research or research that was, enrolling maybe concurrently, or they were planning on doing that in the near future? What do you think some of the downstream effects for those researcher and trials, what will those be?
I mean, I think it's certainly having a large effect. My personal experience here at the University of Pennsylvania, the only research that's going on right now at Penn for the most part is COVID-19 research. So they're following the recommendations for social distancing. The university is shut down. All the labs are shut down. So if you're doing any kind of research that involves you with interacting with anything other than a database that you can query electronically, that research is kind of halted for the moment. I do think we've across the world we've kind of taken a pause from what we've been maybe dedicating our lives to for the prior decade, and shifting gears. So I do think our progress in making discoveries in sepsis and other things may be slowed down for a while, and that's probably something we should keep in the back of our minds.
So what advice would you give to any practitioners who are hearing what you're saying and they're thinking, all right, at this point, I want to try to do some high quality research. Let's start looking into creating research protocols, at their institution. What pieces of advice might you give them? And should we even be trying to complete just single center research like at this time?
Not to create a cliche already, but I mean, the question is, what is the question? So, so it depends though. I think, in general, at this point, if you're starting to design research, I would stop worrying about trying to do it quickly, because you're already, if you haven't started yet, you're already very well behind. I mean, I know that there are multi-center studies that right now that have enrolled like more than 2,000 patients across 50 different ICUs in the United States. So, if you haven't started yet, you're not going to be benefiting from we are the first to do this. So with that in mind, I think now is the time to start focusing more on, let's make sure that we do this right. Maybe we don't have to worry about as much about doing this as fast as possible, because all those folks have already, the rabbits are all out. Right now, it's the time for the tortoises. And so think deeply about your questions, and come up. The first priority always should be to come up with a clear research question, and then whether or not it can be a single center versus multi-center kind of depends on what is the outcome of interest. If you're wanting to study the effects of hydroxychloroquine and azithromycin on QT interval, that might well be done in a single center. That's something that you could do a high quality study with a few hundred patients that, over a year's time, a lot of hospital centers or health systems will have treated hundreds of COVID-19 patients. If your goal is to look at more hard outcomes like mortality or hospitalizations and intubations, those types of outcome metrics, you're likely going to need multi-center studies to be able to achieve, even in a year's time, to achieve sample size to look at plausible effects of treatments. I do think there will be a premium on multi-center studies.
So as we read kind of more and more related to COVID-19, you've mentioned like the word post hoc analysis is something where we should just instantly kind of get our guard up and kind of have a little bit of a red flag as we see that. Are there any other specific things or terms where if you see this in some of this newly released research, you kind of need to say, all right, let's recognize there could be some sort of bias or confounder here and keep that in mind as you read the rest of the study?
Great question. I think we've talked a lot about the things that I think of in terms of red flags, and maybe not necessarily red flags, but small studies will tend to both underestimate and overestimate effects. So even a perfectly designed randomized control trial that was perfect in every way, the gold level evidence, if they only include 20 patients in each arm, that diminishes the information that comes from that study. So small sample sizes, lack of control groups is another thing that, we probably haven't seen the last of those studies. How were patients selected into the study? So, one clear red flag is when you see descriptions of to be included in the study, they needed a minimum amount of follow-up. That nearly always induces some type of selection bias, and certainly would be a red flag. And I think just in general, maintaining a more circumspect approach to reading the literature is probably a good idea.
Now, how are you keeping up with information, in this pandemic time? Because I think that all of us would go crazy trying to read and consume everything that's being published on a daily basis.
I mean, that's a great question. Honestly, Twitter, I think that's one, real benefit of social media if used in the right way. I think the biomedical research Twitter has grown over the past probably 5 years. So that, there are communities of scientists that regularly communicate with each other, discuss research findings. And, you probably have experienced it yourself that before I even see a new paper in my inbox in the journal table of contents, there's already a tutorial about it somewhere on Twitter. So yes. Social media certainly is very helpful. I get the table contents of most relevant journals in my email. And then I think also interacting with our professional societies is also really, really helpful. So, especially right now, the ACCP listservs, critical care ID, every day someone is posting questions that have direct clinical relevance. And what's great about those types of platforms as well is folks are not only discussing new literature, but they're discussing what's happening at the bedside. So even if you were not seeing COVID-19 patients yourself on a daily basis, you can still get a real feel for what's happening at the bedside by being active in the on the listservs. But it's a challenge. I'm probably I'm not aware. I'm probably unaware of a lot of important studies myself.
Yeah, I've talked about some of those listservs before on previous episodes, and they are not sponsors of the podcast. But if you've been waiting for a time to join some of these professional organizations, SECM and ACCP both stand out to me. I know there are other ones that have great listservs as well, but those two for me in terms of having a network of professional colleagues and things that you can run ideas past. And I think we'll see questions or emails in that group maybe a few days to a week before we get this paper that describes new issues related to these patients. Like I remember the question on anticoagulation and that management kind of the question started creeping up on the listservs a little bit before all of the journals and things started releasing information related to it. So everyone should definitely try to sign up and join those organizations. Absolutely.
I fully support that.
Now, hopefully some of the listeners have been enjoying some of the past episodes, and one of the themes is that I want to have some kind of quarantine related questions. You know, we're all adapting to this new normal. So, Todd, what's an entertainment recommendation, whether it's like a movie, TV show, or a book that you'd recommend to the listeners to help with some of their increased free time?
Yeah, well, so I have two young daughters. My oldest daughter is 3 years old. And so I have watched both Frozen 1 and Frozen 2 about at least 100 times over the past month. So Disney movies are great, man. I mean, I had never watched Cinderella or Snow White, but you know what? Really compelling stuff. So those are highly recommended. Yeah, you know, I like Ozark is something that I on Netflix. Breaking Bad, Better Call Saul, I think is even better. So, you know, those are some things, you know, Game of Thrones season 1 through 6. Game of Thrones season 1 through 6 may be the best TV show ever. So if you're one of the people that actually hasn't watched that series, it would definitely be worthwhile. And you could stop at season 6 and you'll be a happier person having done so. The last two seasons, were you a viewer of that series?
You know, ironically, it was one of those where for years I had resisted because I'm not really a sci-fi kind of fantasy kind of that's not my genre per se, but my wife and I, we watched all the episodes leading up until the last season, and then we watched that live, and I've never been more disappointed with a TV show that was loved by the entire country. I mean, we're in the middle of a quarantine where people have more free time than ever for you know, in this era. And yet, when you think of recommendations, Game of Thrones is just not being mentioned. And it just, because the last season was just... I think people have been scarred by the last season. It was, you know, it's like people were traumatized. So, you know, we have like Game of Thrones PTSD that folks are experiencing, I guess. So I think certainly it's worth a watch if you haven't seen it. I'm a big golfer, so I spend, believe it or not, I spend a lot of time hitting foam golf balls in the attic of my house against the wall. That's great. So if that gives you an idea of how much fun I'm having. I mean, I watched the Masters replays this past weekend. I mean, that's where I am. You're at least physically hitting the golf ball. I'm not a good golfer, and so I would just like to watch it. And the Masters is one of those, you hear Jim Nance's voice. It's just, it feels right. Well, Todd, this was great. I think, and I can speak for myself, and I know a lot of the listeners as well. I think we're all going to feel a little more comfortable with interpreting and evaluating these rapidly released studies. I feel like the longer that we talked, the less confident I am that I've read anything with remote relevance or substance related to COVID-19 in terms of independent research studies.
Yeah, well, sorry to be such a downer, but you know, I appreciate the opportunity, and I've really enjoyed talking through these issues. And you know, kudos to you. I think it's a great idea to broach this subject. It's something that we all need to be talking about.
I appreciate that. Now, Todd, what's your Twitter handle for those who may want to reach out to you?
Yeah, so the Twitter handle is Miano81, Miano81.
Okay. Well, thanks again, Todd. I really appreciate your time and expertise.
Yeah, absolutely. Really enjoyed it.
Another huge thanks to Todd Miano for taking the time to join us today. I also want to give a massive thank you to you, the listeners, because obviously this podcast doesn't exist without you, and I greatly appreciate your support. I hope everyone is able to take something from this episode related to research and statistics, not only in the era of COVID-19, but also afterwards. I think it's really going to be helpful. So please send me feedback, positive and negative, as well as any guest or topic ideas, Twitter or Instagram at PharmacyToDose, that's TO2Dose, or via email, PharmacyToDose@gmail.com. I'd honestly love to hear from each and every one of you, so please reach out. On our website, PharmacyToDose.com, you'll find the show notes from Todd and I's discussion that gives some bullet point formatting from some of these from the Q&A that we had. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.